Okay, good afternoon. Welcome to the Firefighter Cancer Initiative monthly seminar series. We're going to give a few minutes for the room to populate. So if you just hang tight for a minute or so, we'll go ahead and get started with our presentation. Sir, if you're joining us, we'll get ready in just about a minute or so. So please hang tight. Okay, so it looks like we're pretty stable with everyone that has just joined us. So I'll go ahead and get started. Good afternoon. My name is Alberto Caban Martinez. I serve as the Deputy Director for the Firefighter Cancer Initiative that's housed here at the Sylvester Comprehensive Cancer Center at the University of Miami. You're joining us for our monthly Firefighter Cancer Initiative series. And we're really excited. We have a very special topic today that is going to be presented by our own FCI team. So joining me today is Dr. Aimee Green, our nurse practitioner and lead on our Firefighter Cancer Initiative, as well as our nurse navigator, firefighter, paramedic, Johanna Garibaldi. You know, the Firefighter Cancer Initiative is often known a lot for its research and the work that we've been doing over the past couple of years to inform firefighter health and safety. But I guess one less known component of ours is our Firefighter Wellness and Prevention Clinic. You know, healthcare delivery is one of our important missions, and that is true of the Firefighter Cancer Initiative. So much so that today we're going to highlight a really important aspect of FCI, which is our new Firefighter Mobile Clinic. And so we're inviting our team today to give you a presentation. So I'll turn it over to Joe and to Aimee. Just one administrative note before they go ahead and get started and queue up their slides if they want to, which is how do you ask a question? So on your screen, there's a Q&A portion, and our preference would be if you wouldn't mind popping in your questions into the Q&A, and my colleagues, Dr. Schaefer and Ms. Cynthia Theory or Tara Greenberg and I will moderate those questions as they come through for our presenters. So without further ado, I'll turn it over to Joe and to Aimee. Thank you.
Sure. Hi, good afternoon, everybody. Hope you guys are having a great day. So today we're going to talk about the mobile firefighter clinic that we started with the initiative. So this is Dr. Aimee Green and I. So our learning objectives are to review cancer burden and health disparities in the fire service. We're going to examine the current guidelines and health screenings right now that are giving us direction to what we should be doing for firefighters. We're going to summarize the health concerns from firefighters and different organizational levels within the department. We're going to describe the Firefighter Cancer Initiative Mobile Clinic, and we're going to analyze baseline data from the moment we started the mobile clinic back in January. And then last, we're going to talk about what are the next steps moving forward. So cancer burden in the fire service. So as we know, there's a lot of research that has been done about this. So we know that the IARC, who is the International Agency for Research on Cancer, rated occupational exposure as a firefighter as a possibly carcinogenic to humans, right? So really important is there's going to be a meeting coming up in France, where Dr. Caban is going to be there to discuss how we can change this into a possible, to like the reality of what we're seeing. So hopefully we see some changes there in the near future. The other thing is, you know, we see elevated overall cancer risk. So again, based on the research that has been done, we've seen that there's an overall cancer increased risk of skin, multiple myeloma, lung, colorectal, and GI, prostate, bladder, testicular, thyroid, kidneys, and lymphoma. And then obviously there's some that are very specific, elevated incidence of mortality in this other type of cancers. So what are the other health disparities in the fire service, right? So we talk about obesity, lack of sleep or interrupted sleep, right? We all know that call at 3 o'clock in the morning that gets us rushing, and all of a sudden we're like ready to go. Hormone imbalance as well, cardiac health, mental health, and then hearing loss. So what are the current guidelines that are out there right now? So as fire departments, we rely heavily on the NFPA, right? So the National Fire Protection Agencies, they set standards that fire departments should follow. So this is all to keep, firefighters safe and keep some sort of a level of organization. So the NFPA 1582 is a great guide to know what is being recommended right now. And also the American Cancer Society and the United States Preventive Task Force. So those two are the ones that set the standards for the general population that are at average risk. So that is the key word, because firefighters are obviously not at average risk. So we can take and utilize 1582 with the American Cancer Society and the Preventive Task Force to create guidelines for firefighters. So through published research from Dr. Jenke and Dr. Sali, we're able to figure out what are some of the health concerns among firefighters. So cancer obviously was one of them, chronic disease, heart health, sleep, again, it's a common concern. Stress, obviously the exposures, the physical activity, and then things like food culture in the fire service, right? We don't always make the best choices, especially again, that call at 3 o'clock in the morning, you come back, you're hungry, you want to start munching, not necessarily on the healthy stuff. Injuries, trauma, and then on women's health, obviously as well, things like infertility and hormonal imbalances, and then infectious disease. So the other thing that we found through this is Dr. Caban's research is we're trying to understand what are the organizational level factors that are affecting these screenings, right? Why aren't we having more screenings within the fire department? And we found out that those there were, or what was helpful is having 2 or more health and safety officers within that department. So that actually drives more of like the prevention and health, overall health of the firefighter, just having 2 or more safety officers that are involved in that. The other things is, that are not so helpful. Well, obviously the fire department size, the budget, geographical location, the degree of leadership support, right? Because it's a trickle down effect. So we need to be as leaders, supporting our firefighters on the ground and just, move it down. And then the type of department, right? Because there's a difference between volunteers, careers, and whatnot. So I think this is a $1 million question that we all want to know, right? What screenings should be included as part of the firefighter annual exam? And I'm going to pass it over to my colleague so she can share some light.
So although definitely this is an area that research is currently being done in, I know as part of the FCI team that we have lots of projects going on, focusing on improving the guidelines and what clinical screenings are required. This is a starting point, right? So we took into account what the current guidelines are, right? NFPA, regular general population guidelines. What are the health concerns of firefighters, right? Because cancer is one of the health concerns, but there's also other health concerns that include chronic disease, mental health, things like that. And then what are the key components of having those organizational level changes? So we took all of that information, right, and put together, right, these key components of what entails our firefighter cancer initiative, mobile clinic, comprehensive occupational medical exam. And of course, the first thing is the comprehensive history and physical. So any clinician will tell you that the history and physical is our bread and butter, right? That's when we get to know our patient. Very important to take the time to not only talk to our patients, but also do a very good physical exam, right? We can pick up things through those 2 very simple techniques that inform us as to if we should be performing additional screenings above and beyond the regular screening guidelines. Next is lab testing. So lab testing is another very critical key component. Simple lab tests such as like a CBC or urinalysis can give us a lot of information as clinicians as to if something is going wrong in the person. So doing those detailed lab testing is another tool that we use. Then we also want to screen for things like vision and hearing that are obviously important to being a firefighter. You need to be able to have those things, and then also to pick up, right? So if hearing loss is an issue, we want to make sure that we're tracking that over the lifespan of the firefighter to see if those changes are happening, and how we can mitigate that. And then lung health, heart health, same, right? We have here in Florida, we have the heart bill. So certain things are covered as occupational related conditions. We want to make sure we're screening for that. And then in the general population, right? Heart health is still cardiovascular disease is the #1 killer still in the US. So definitely we want to screen for those issues. And then infectious disease, because of the nature of the work and the fact that you're on the back of a truck with strangers, there's real possibility of getting exposures to things like tuberculosis, hepatitis, HIV. So we want to make sure we're including that as part of our exam. And then mental health, sleep, and hormone health. So that's kind of a 3-part. So mental health is important to screen for, right? Because of due to the nature of firefighting, different people cope with things in different ways. So we want to make sure that we're screening for any kind of mental health basically issues, and make sure that our firefighters have healthy coping mechanisms for the nature of their job. The other thing is sleep disturbances. So we have a multi-item sleep screen that we do to check for different things like insomnia, restless legs, sleep apnea, things like that, which are all sleep disturbances that can be related to shift work. And then the other thing is hormone health screening. So because of the nature of the job, the stress associated, and that sleep interruption, firefighters are at risk for hormone disturbances, both sex hormones and stress hormones. So we want to make sure we're screening for that. And then, of course, cancer screenings, right? That's where it all started. So I'm going to go into a little bit more detail on the head to toe of the cancer screenings. So what we do for cancer screenings. So I'm just going to go, so I'm a clinician, so I'm just going to go head to toe on my little body diagram here, right? So brain, there's no standard screening for that, right? That would be always symptom-based if we end up ordering any kind of workup. For thyroid, we use a combination of the physical exam, right? So I examine the actual thyroid, and then we do a very detailed lab panel to help augment that. There's also a thyroid study being done right now that's headed up by our very own Dr. Sully, that's looking at if it's beneficial to do a combination of both the clinical exam, the thyroid labs, and also imaging, ultrasound-based imaging, and how that either augments our ability to screen or not. So that study is currently underway. Then for lung, we're going to do a tobacco use history. So tobacco use is still the #1 link to lung cancer. So we do follow the standard guidelines on low dose lung CT for lung cancer screening. Little caveat though, since we do a screening for heart health, which is a calcium score, through that imaging test, we're also able to see the lungs. So we've been able to kind of use that as like a double whammy for screening, even though that's not an actual lung screening. The other thing, right, so then we have our abdominal organs. How do we screen for those? So we do a comprehensive metabolic panel, which gives us indication on like what's going on in the liver, what's going on in different abdominal organs, and then history, and then also the physical exam, which I palpate to see if there's anything abnormal. I should be palpating organs and whatnot. So shouldn't feel anything there. So that's part of the exam. Then also for renal and bladder carcinomas, we get a urinalysis, and of course history physical is going to be for all of them. Prostate, so in the general population, PSA is basically used starting at the age of 50 for average risk people, right? Then for high risk people, so culturally, like African Americans are at higher risk for prostate cancer, but firefighters are also at increased risk. So we put them in the category of high risk. And those guidelines start at the age of 40 is when we can start with a PSA. A couple caveats to that is if there's a family history of prostate cancer, we can start earlier, or if there's hormone therapy use, because people that are specifically men that are on TRT, it's something that gets monitored because some of the studies have shown that while you're on TRT, it can raise the PSA. So it's something that we keep an eye on. The other thing is for colorectal cancer, right? We're going to do our fecal globin tests annually. And then colonoscopies on the general population start at the age of 45, but on our firefighters that are high risk, right, we want to start most of the time when we talk about high risk populations, we're going to be starting screenings 5 to 10 years, prior to the general population. So at 40 is when we start recommending the colonoscopy. And then for oropharyngeal and esophageal cancers, we do, again, a very detailed history: alcohol, tobacco use, GERD. These are all risks for these cancers. So looking at the risk factors there, and then referring as needed, and of course doing a physical exam, recommending oral hygiene as well, and tying that into our clinical recommendations. Then for hematologic cancers, a simple CBC shows me what's going on in the red cells, the white cells, all these things that would put firefighters indicate that there might be something hematologic going on. And then full body skin checks at least by the age of 40, because in firefighters specifically, we see 40 and beyond is when there's increased risk for melanoma, which is like the bad skin cancer, basically, right? And then for our female reproductive, right, breast, cervical, pelvic, we do recommend having a relationship with a GYN where you can have your well woman exam annually, which just means you're going to go to the doctor and they're going to decide what screenings are right for you. There's different cervical screening, cervical cancer screening guidelines, HPV screening guidelines, but they're all based off of your personal history. So there's no way to just give out blanketed guidelines without actually knowing someone's history, if they've tested positive for HPV in the past, what's going on with different things. So definitely recommend going to the GYN annually so that you get that comprehensive exam. And then if you need HPV testing, cervical cancer testing, it gets done there at that annual exam. Mammogram on the general population starts usually, depending on what guidelines, right? Every other year, I think, is what NFP says at 40, and then 50 is when it's annually. But for the most part, insurances will reimburse up to the age of 40 for that screening exam, right? So for female firefighters, it's a good idea to get started at least by 40. And some people will opt, if depending on family history, risks, things like that, for a baseline mammogram at 35. And then, of course, if someone has a symptom, we'd be doing something. And then for a male reproductive, we recommend, so we do teaching on self-exam and self-awareness for testicular cancer, and we'll talk about that a little bit more at the end. All right, so that was an overview on what we do for cancer screening. So this is just an overview of our clinic workflow and how we've been able to implement the mobile clinic into our pilot department, so to speak. So it starts with the mobile clinic visit. So on the mobile clinic visit, we'll give a tour at the end, but we bring the vehicle to the department, to a particular station. We are on wheels, so we can't go to different stations. But we've been coming to one station, and we set up shop. We do labs there. We do the history, the physical, everything that's done that day of the visit. If there's anything that needs to be ordered, such as the calcium score, anything like that, then that order gets put in and they get a phone call to schedule it, and they go to the actual physical location, right? We don't have a CT on here. We can't make this radiation proof. So they actually go to the physical location to get any kind of imaging like that done. Then on the follow-up visit, that's done via telemedicine, right? So most people do it just hop on their phone, log on to our MyChart portal, and then we review the lab results, review their history, review anything that they've done imaging wise, and we come up with basically like a plan of action on what we're going to do for follow-up based off of what's going on in their health. And then lastly, right, would be if they need it based off of all their results, is if we need to refer them to one of our specialists, which we also do. Again, they can go anywhere they want, but we obviously through our services with Johanna and our nurse navigator, sometimes we can basically we treat our firefighters like VIP, which you guys are. So next, right, is when we've met with different departments, there's different needs that the fire service has that are different than the regular population. And I think it's really what we've seen is a lot of departments provide different things to their firefighters, and a little bit sometimes the services become either duplicative or triplicative, right? So we have these three categories of things, being the occupational health exam. So a lot of departments require like a fit for duty type of exam, right? So but that exam oftentimes overlaps with what their family medicine doctors doing. So a lot of the fit for duty lab testing, things like that, or similar to what you would have at your physical exam with your family medicine doctor. And then cancer screenings sometimes fall through the cracks, right? Depending on who you saw and, you know, if they're familiar with your risks or not. So what we wanted to do with this mobile clinic was make sure that we were providing all three services in one and catching what cancer screenings were due, treating the whole patient, right, head to toe, not just cancer, family medicine, and then the occupational health side is making sure that they're safe to work. So that's how we guided also the comprehensive nature of our visit. And then why mobile, right? Like, why do we want to be on this truck? And part of that, right, was because of the feedback that we got. So firefighters tend to be very busy people. Some of them have multiple jobs, they have families, they work long hours. The last thing they want to do is go to a doctor's office on their day off. And oftentimes, you know, I'm a clinician and tend to run behind sometimes, right? So oftentimes you're waiting at the doctor hour, 2 hours, right? And it's not what you want to do on your day off, especially after working the 24-hour shifts. So we wanted to increase accessibility, right? So bring it to you. So like there's no excuses. It's here. Where else are you gonna go? You're here for 24 hours, right? So come see us. Decrease barriers to care, because again, all of those things, the timing is a barrier to care. The fact also that, you know, who wants to sit in a doctor's office with a bunch of like sick people around you? That's another barrier to care, right? So this is the back of a truck. They feel right at home. So that's been great. And then increase utilization, right? So not only making it accessible, but actually increasing the number of people that will participate because they're willing to do it because we broke all those barriers. And then decreasing costs, right? Because we're getting rid of those duplicative, triplicative services, and we're using evidence-based guidelines to perform these services. So a lot of the things that we do are reimbursable through insurance, right? So we're decreasing that upfront cash cost, which leads us to our next thing, which is the reimbursement model. So the model that we're currently using is this combination model, again, because of most of the things that we do are evidence-based, then we can bill insurance for a lot of the things we do and maximize the fire departments or whoever's allocating the funds. But there are other models that would just be insurance-based or cash-based, full cash-based, but kind of using the insurance for what they pay for. And then if there's something above and beyond that they don't pay for, then saving those funds for that to be able to maximize what you're able to do for your department. So our pilot department, it's probably like cats out of the bag already, but has been City of Hialeah. So they've been great. We've been here since January, and they've been our pilot department, learned with us, grown with us. So thrilled for that. This is a picture of the ribbon cutting with the Sala Foundation, which was actually the foundation grant that Dr. Kobitz applied for and got. And the Sala Foundation so graciously provided the funds for this mobile clinic. So we're grateful for that. So this is going to be some baseline descriptive statistics of what we've been able to accomplish with the mobile clinic. So far we've seen about 130 patients or so. And basically what does that mean? That's just a number. But basically, when you see our FCI mobile clinic is the bulk of what we're seeing, whereas in our standalone locations, the volume is not as great, right? So again, proving that firefighters don't like to go to the doctor. They'd rather come here to our mobile clinic. And if they're going to do anything, they're going to hop on some kind of telemedicine visit, but not physically go to any of our locations. So with this, we were able to basically 95% of our visits have been new patient visits, which is great. We're increasing the amount of firefighters that are being seen and haven't been seen with us prior. And then the other thing we're able to do is increase our clinic volume and use by greater than 200%. So when we compare 2021 numbers to 2022 launching the mobile clinic, it's been a big growth. So that's what we want. We want prevention for our firefighters. This is just some basic demographics. So of course, similar to the general firefighter population, mostly male, smaller percentage of female. And then the cool thing is across the lifespan, we've been pretty neutral. So even snuck in a 15% of our 20 to 29-year-old range, which, you know, most cancer screenings, as you saw from the cancer screening slide, start around the age of 40. But we've still been able to capture the younger group of firefighters because not only are we providing actual cancer screenings, but we're providing education on what you can do, preventative lifestyle, and also on the job, right? Like all the decon stuff. So that's their distribution there. Demographics has been, of course, mostly Hispanic, mostly white, not surprising for our South Florida here population. And that was a breakdown of basically who we've seen so far. So next steps that we have, right? So our goal for our clinic is to decrease cancer and chronic disease rates and deaths in the fire service. And how do we want to do that? We want to do that by increasing access to these screenings and preventative healthcare and education. So basically putting all this information and tools in the hands of the firefighter, the boots on the ground people. And then in doing so, we want to establish best practices for cancer screenings and general health screenings in the fire service, right? Like come up with something that's founded in all this research that's being done on firefighters. So next steps, we'd like to expand our services to other departments in South Florida. Obviously, we're going to be analyzing data to see how we can improve this. That's ongoing. Obviously, like in research and academia, we always want to improve what we're doing and refine what we're doing to meet basically the needs of the fire service. And then also as current research expands, incorporate the latest and greatest research into what we're doing. And then of course, seeking additional funding to hopefully be able to replicate this model as we grow. These are our references. Oh, and then one more thing before we wrap up, because then we'll open it up for questions, is April is Testicular Cancer Awareness Month. So couldn't go without doing our teaching for testicular self-exam. So right now there's no guidelines that are standard for testicular cancer screenings outside of basically the ability for you to do a self-exam. I usually compare it right to like the breast self-exam. So there's this is something that you should basically become familiar with the testicular self-exam and become familiar with your testicles. So the way to do that is basically examining yourself. You would cup one testicle at each time. A good time to do this could be in the shower. I don't know who takes baths as adults, but if you take a bath, great for you. So you can do it at that time and you would just cup one testicle at the time. Basically, you're just feeling for any lumps, bumps, anything out of the ordinary and familiarizing yourself with what's anatomically normal versus what is not normal. Some people, you know, enlist the help of their partner if they're more familiar with their testicles. So it's another thing that you can do. But basically the important part is feeling for anything that's out of the ordinary. If there's a question, if there's, I'm not sure if this is normal or not, then that indicates going to your doctor, having them perform an exam, and then if indicated, we can order different imaging that would go into more detail on if there's anything that because there's things that are, malignant, and there's things that are benign that you could be feeling. So definitely self-exam is first, then clinical exam, and then if we need, we can use imaging. So if anyone has any questions about our mobile clinic or about anything that we talked about, here's some pictures. We can also do like a brief tour. I don't know if to do that now or after the questions, but that's some pictures, and then we're actually obviously like.
So I'm gonna stop sharing the screen just so that we can see each other.
Awesome.
If there's any questions in the room, and then if not, then we'll show you guys around.
So Amy Jo, this is awesome. Thank you so much. I wonder if before we start entertaining questions, you might get some more questions about actually the layout of the van. So why don't we just spend a few minutes first before we do the Q&A? And if you wouldn't mind showing us around, what does the van look like and the experience for a firefighter?
Apologize for the movement, but bear with us, okay?
So
So
you wanna,
usually,
like, do it from like them coming in.
so usually this is when we come in. So we have our sink here. This is our my workstation actually. We have the sink here. Obviously we're in it's a small van, so we have to utilize and maximize the space. So once we have started, the console, then this is where I'm trying to find the camera. Okay, so this is our sink. This is where we process our urine, our blood with our centrifuge. Then this is, I apologize again, our lab station. This is where we do our EKG and our audiogram. Okay. And then we come around, we have a visual acuity test. We're actually very excited because we're getting new equipment where we can optimize the vision screener for firefighters. This is the patient bed. And then this is Amy's workstation / vital signs. So as you can see, we've utilized every single inch of space that we have available. And then, on the outside, it's the beautiful.
Do you want us to show the outside?
If you can step out for a minute, sure, why not? If you can pop out and show them just the outside view.
So we're actually at Hialeah. We're seeing patients as we speak. So
That's awesome. You guys are great.
Yeah, so it's a really nice
this
printer.
is the one side, so it's a nice printer, and then we just do a full 360 of it. I know the sun isn't helping as much, but hopefully. So up top, we have the hashtag extinguish cancer. That's our own handle that we use for the FCI. And then we come around. As you can see, we work off of shore power. We have batteries as well. Obviously, we emphasize the decal with the screening. And then last but not least, our State Fire Marshal and the Sala Foundation that so gracefully helped us put all this together.
That's awesome. So why don't you guys go ahead and grab a seat, and we have a couple of questions for you.
Perfect.
We're ready to shoot at you. Okay, so
We can answer. Oh, sorry, Alberto. I was going to say, since we're waiting for Joe and Amy to get settled, we can answer one of the questions where they're asking about how is the mobile clinic funded, personnel, vehicle, supplies, labs, etc.
Yep.
So as you saw on the back, we had the State Fire Marshal's office. We were able to allocate some of the funds from the FCI funding that we received. But we also were very fortunate to get a foundation grant from the Sala Foundation, which really sparked this, the actual purchase of the vehicle. So a little bit of both.
Awesome. Okay, so one of the other questions that we received from our audience today is, what cancer screening tests are different than a regular annual visit to the primary care physician, except say for colorectal cancer?
Yeah, I would say, so definitely for colorectal cancer, that one, I'm trying to think. So the difference between this and a primary care may not be so many with the screenings. There may be different screenings, obviously, that we're looking for, but because we know firefighters risk, right? So some unfortunately, the art of touching your patients and talking to your patients has been a little bit lost. So something like a thyroid exam may get missed by a regular doctor. Should it be done? Yes. Does it get done? That's a different story. The same thing, right, with labs, because on the thyroid we know there's increased risk because of the chemical exposures of like PBDEs and things that mimic thyroid. Then basically we're gonna go more detail on doing certain lab testing. So I think the question is, there may be nuances. The answer is there may be certain nuances within the screening that we do in more detail than a regular doctor, just because we're familiar with firefighters. And then the other one would be the PSA. The PSA is usually something that the prostate screening in the blood. But that's like a conversation that you're supposed to have with your physician, risk versus benefits of screening, because there's other things that can elevate the PSA other than prostate cancer. But with firefighters, since we see that increased risk for prostate cancer specifically, and the PSA is a very simple blood test that we can do. That is something that we start younger as well. And then I think, again, just being a little bit more aggressive if there are any symptoms. If, let's say, someone's white count, it's supposed to be 4 and it's 3.8 or 3.6. Why is it 3.8? Why is it 3.6? Let's repeat it. Is it still like that? Let's, refer to hematology earlier than like a regular, right? Whereas a normal doctor, it's a little off, but it's probably fine. And then 2-3 years later, we end up with a problem, a full-blown problem that could have maybe been caught earlier.
Yeah, I think the difference also is the fact that we have the knowledge of all these exposures that firefighters have, right? So most of the general practitioners, they ask on your, when you go in on your intake, what is your occupation? And you normally answer nurse, paramedic, firefighter, whatever, but they don't take that into account when they do your physical exam, right? So they don't really take into account all these exposures. So it's actually, believe it or not, is not common knowledge that firefighters have like these problems with cancer in the fire service. I've had conversations with oncologists that have been in practice for over 20 years. They're very good at what they do, and they had no idea that firefighters were at increased risk, like for a breast, for a female, right? So for me initially, having just left the fire service and now being in this role, it was a little bit eye-opening, because I was like, what do you mean? I thought everybody knew this or everybody took this into account. But it doesn't always play that way, right? So I think that the difference with our clinic is that because we have this knowledge, we're able to specifically for cancer screenings be a little bit more aggressive about, but just in overall health in general too, just do a little bit more deep analyzing other things that most providers wouldn't.
Awesome, that's great. Okay, so we have another question for you. And I think you may have alluded to this earlier, so if you want to queue up the slide, that might be useful. But do you have data on what is the percentage of firefighters that are participating in screening per department? In other words, how many total firefighters and how many do you see participate in the firefighter mobile van?
Per department, so out of Hialeah has, I think, somewhere between 180 to 200 firefighters. We have seen about, I think so far, we're somewhere between 130 and 140 after this week. So I think when you do the math, we're somewhere around the 60 to 70% mark. My goal would be 75%. That's my selfish goal. Her goal is 100%. So this fire department doesn't, so unions have different guidelines and things like that. So, and fire departments themselves. But this department doesn't require them to do an occupational health. Like, this is not their mandatory exam. They do have like the hazmat. The hazmat has is mandatory, right? But this is not a mandatory physical for them. So there are other departments that do make it mandatory. I think in the fire service, the word mandatory is like a double-edged sword. Because sometimes when someone's told they have to do something, then they don't want to do it. But if they're given the choice, then they'll voluntarily do it. So we have had, I think, what's definitely good participation so far, and we do plan to kind of look into what are the reasons, like what are the barriers they're still seeing. Is it just because they already have a family doctor and they just prefer to stick with them, or are there any other barriers that we can help address?
Awesome. Okay. So Joey, we have another question here. Could you comment on what are your thoughts about cancer screening blood tests or say a body scan? Do you recommend any as an additional screening test for say a concerned firefighter?
Unfortunately, things like a CA-125 and different kind of cancer markers that are out there are being marketed as useful for prevention. Unfortunately, when you look at the research, because we have had people reach out with, hey, my marker is XYZ, what do I do? I've dug through the literature. There's nothing out there. There's nothing on what to do if you don't have cancer and one of your cancer markers are elevated. So it kind of leaves the clinician at a point where now I have to go and do a very detailed history and physical and try to figure out if maybe there's cancer somewhere, or maybe it's just benign, right? Because there are benign reasons, just like the PSA could just be because you went on a really long bike ride, right? And then you had your PSA done, right? Or you know, we're looking into different reasons, right? But there could be another reason that it's elevated. So that doesn't tend to be useful. As far as the whole body scanning, the issue with that again is usually there's going to be indications like with the testicular, right? So if you do your testicular self-exam and you find something, then that's indications where then I can go ultrasound it. Same thing with the thyroid, right? If I can palpate, I'm not sure, maybe I didn't feel, or maybe I felt a small nodule or something's off in the lab, then that can indicate that I would need an ultrasound, right? But we're kind of putting the cart before the horse and just like whole body scanning things. Same thing with the kidneys, right? If there's blood in the urine, that would indicate maybe we should ultrasound the kidney, the bladder. So we kind of do it more in an evidence-based order than just blindly screening head to toe. It tends to be a little bit more, in my opinion, a little theatrical versus like actual need for things.
The other thing is, you know, as clinicians and as, you know, people that work in the medical field, right, we rely heavily on evidence-based, right? Evidence-based practice. So, you know, if you're a firefighter, you go on a call, somebody that has chest pain, we give them aspirin because evidence told us that that's what we need to be doing. That's the steps to go. And, you know, we've done the research and that's the treatment that we should be following. So the same thing goes with a lot of these tests. And that's how I try to explain it to other firefighters that have the same question is, you know, we follow what is out there. What's the evidence? You know, if anything comes up and gets published and says, hey, this is what we should be doing. Let's do ultrasounds. Let's do this. Then, you know, now we have evidence as to why we should be doing it. But I think that's also really important to have because, you know, again, we can do tests, but we've had cases where, you know, it affects more of like the life of the firefighter without knowing what to do with these results. And it's just kind of like a double-edged sword.
Okay, awesome, terrific. All right, so another question for you. So is there a flyer or a handout that also describes the recommended head-to-toe screening that can be used by those outside of South Florida area to help them know what should be they doing for different tests that they should be getting or at least be aware of?
I think that may be on the horizon, something that we're working on together as a research and clinical team. So stay tuned for more of that, but nothing yet.
Yeah, we're hoping that a lot of, you know, there are professional firefighter organizations that have documents available. So for example, the International Association of Fire Chiefs has a document about physical exams. But I think the uniqueness or innovative part of this is that the clinic will inform the research and the research will inform the clinic here to, you know, make those determinations of whether different age or different type of testing should be done on the first responders. So it's not a quick fix. As you all know, science takes a little bit of time, but thanks to our firefighters, we're able to learn both how to improve the clinical operations and delivery of what firefighters need and want as part of their annual healthcare and screening and prevention, as well as the research that needs it. So we're getting close to time. There's just a couple more questions here. I want to remind our audience, you're asking great questions. Please post them in the Q&A so Ms. Greenberg can help us filter through them. Our next question is, could you comment on who is doing these screenings in the mobile van? Like which healthcare providers are doing it? Is it nurses, nurse practitioners, physicians, or all of the above?
Yeah, so so I am a nurse and Aimee is a nurse practitioner. So we are the ones that actually come to to the stations and do the physicals. But we do have Dr. Chris Paul, who's our medical director, who oversees everything, and we work really closely with him. So it's more like a team approach. Anything that is ordered, right, like an imaging exam is read by a radiologist and then it gets sent to us. The same thing with the labs, right? So there's very specific, because we are part of a health system, you know, then it's we tag team with the rest of the departments to get like a more comprehensive approach. But the team is us, Aimee and I.
Awesome. Okay, could you there's a question from the audience about curiosity about whether this mobile clinic is common across the nation for firefighters only. Is this new or
So
unique? Yep.
you know, to be honest with you, I know that there's different products out there. I don't know necessarily who's tied up with the health system. I think I want to brag and say that we are the only ones that were part of an actual health system, but I could be totally wrong. I don't know for a fact, but I do know that there are other mobile, you know, services. But like I said, since we are part of a health system, then it makes us a little bit more comprehensive. So.
And then it's a little different than someone that's going to come and set up shop at the place, because since this is a mobile clinic, Medicare and like CMS insurances consider this an actual place of service, a place of service 15. It's a mobile clinic. So it's an actual like licensed clinic versus when you're going to go through someone that's going to do something like cash based, then you don't need it to be a licensed clinic. They can just set up shop anywhere in your classrooms or whatever. So it's a little bit different. This is like a fully licensed mobile clinic through CMS.
Yeah, and I would argue that you guys, your lens is firefighter. So really your orientation and primary sort of thinking is, you know, how to navigate the firefighter through, you know, the health and the clinical system. So I think that's very unique. Okay, so we have another question here. Does your mobile unit travel throughout the state of Florida, or are you just in Miami?
So, so right now we, like we mentioned earlier, right? So City of Hialeah was our pilot program. So we just started with them. Our clinic was initially created back in 2019 and we were at location, right? But because of the feedback that we received, we got the mobile van. So our goal is, yeah, to be able to expand and you know, move further, move across the counties and reach all the, at least the Tri-County area, little by little conquer, but.
I think FCI, our reach is really like our focus is for our services here is South Florida. And then, you know, moving forward, can this be duplicated in other areas? We do have a lot of firefighter partners throughout the state, you know, Central Florida, North Florida, things like that, that we're able to partner with, you know, other health systems, other organizations that want to do the same thing for their firefighters, right? So we can't be everywhere, but we can share the model and you know, hope that other people can do similar things.
Absolutely. Would you be able to comment a little bit? We have, I got some questions here about sort of like the business plan and the business model of the van. Could you comment a little bit about when you do travel, what are some of your anticipated or experiential costs with delivering the service? And similarly, like the insurances that you accept, could you talk a little bit about what that variation is?
So as far as, okay, so let's talk about insurances first, because it's the most complicated subject, right? So I think what happens with insurance is we have to be able to, or your insurance has to be able to have mobile services included as a benefit, right? Because we are, Aimee is credentialed under family medicine, so that would make her available for you to see with like a very minimal copay and things like that. But when it comes to the actual visit in the mobile clinic, we have to have that component. So as of right now, and we can speak to, you know, our pilot, right, with the City of Hialeah, we've had, they currently have used 2 insurances. So one of their insurances does not have mobile services included in their plan, and the other one does. So for the the one that doesn't have, we created what's called a guarantor account. Basically, they have a set amount of money that they want to, you know, allocate for this expense. We see them, they get, everything gets documented right in our electronic health record. And then there's a bill that's created that goes directly to the city, and that's how they pay for it. Obviously, a lot of the things that we have on the van have been, you know, courtesy of, or like we've been able to acquire because of our grants. Things like supplies and things like that are also like included on there. We have perks with like Quest Diagnostics and the different lab supplies where lab places where they give us the lab supplies. So we don't have to rely on purchasing those separately. It comes with the contract.
I think the biggest cost after you put the actual clinic together and would get funding, because that's like a big hit, right? It's like putting the whole initial thing together would be ongoing fees, would just be any, you know, supplies that your consumables and then staffing, right? So we do run just the two of us, so we joke sometimes, but there's not a lot of space. So we like the fact that it's just the two of us, but that does help, you know, with costs moving forward of, you know, keeping it the team streamlined, and then, you know, just your consumables. Those would be like the two greatest, I guess, costs to consider, you know, to move it forward. And then depending on your reimbursement model would be how much, you know, profit are you making off of like seeing, right? Like how much is the insurance reimbursing versus if it's a cash model, and do you break even with your staff and your consumables, or, you know, is there a loss that's going to be taken, and how will that be handled, like from a financial perspective?
Yeah, very important points to think about too when you know, working with the clinic. So two more questions for you. You guys are doing an awesome job. So here, in terms of NFPA 1582, in your opinion, do you think that's a good enough standard for firefighter physicals? And if no, what would you recommend be added? So Joe, I know you have experience on the NFPA technical committee, so you understand very much where these standards, how they're developed and how they work. So I wonder if both you and Dr. Green wouldn't mind commenting for this participant. Yeah.
Yeah, so I think the now, like Dr. Caban said, right, now that I had the opportunity to be part of one of the committees, I understand better how it is, right? And what I do like about 1582 is that it's a group of, there's people that are occupational health physicians, there's firefighters, there's so many different people that take part of this committees to come up with like the best recommendations, right? Now, the caveat with NFPA is that their recommendations, and you know how there is for you, for those of you that are familiar, there is the shalls and there's the should, right? So I think the one downfall is that we're not really implementing at least these things. So like we should be sticking to the shall and utilizing them because they're great. They're great reasons. It's a good place to start because there's nothing really out there that says what we should be doing. And I think that's the ultimate goal for us, is to be able to utilize at least 1582 that takes into account your profession, and these group of, you know, people all came together and brainstormed, hey, what are we doing? Let's try this. And then obviously utilize that and be able to, in the future, create this best practices, right? So that everybody can use across the board. But I think 1582 is a great tool, at least to start, because it gives you, you know, there's rationale behind it. There's, you know, like I said, different team approaches to know, like, maybe this is what we should be doing.
No,
right?
it is comprehensive. Like it does take into, they just added, so that if for those of you guys that are familiar, they just changed the version now in 2022. They added in hormone health, so it's kind of like they know what's going on, like with our firefighters. I thought that was pretty impressed. They added hormone health, they added mental health. Things that are very like current and real to the fire service above and beyond the cancer screening. So they do adapt them. The other thing is a cancer screening is only, or cancer screening recommendation or guideline is only as good as actually having the screening or guideline done. And then what you do with the information that you obtained, right? Because you can go get a physical done or go get some testing done and then do nothing about it. Or you can know that you should have a colonoscopy at a certain age and then not get it done. So I think it's like Joe said, it's a great start. Is there something that can go like above and beyond? That's what we're trying to determine. Unfortunately, the guidelines that we have in the US are based off of the general population, the US task force, which clearly do not apply to firefighters. So that's where the research, you know, we need that 10-year lag, 20-year lag to like catch up so that we can, you know, do best practices for our firefighters.
Okay, and our last question, I promise, which is family support is really excellent, you know, to add encouragement for firefighters to participate in like this type of delivery. Publicity addressing firefighter families to help support this initiative might be a really great supportive method. What are your thoughts?
Oh, absolutely. If I could have a meeting with all of the wives, girlfriends, partners, significant others, and enlighten them about this first. And you know, as guilty as I am from knowing, so from being in the fire service, you learn a lot of things, right? And I quickly realized when I came here that we're all cut with the same. There's a Spanish saying, right? Cortados con la misma tijera. We're all cut with the same pair of scissors, and we are. So it's usually whenever there's a health concern is usually driven by somebody else, the parent, the family member, the girlfriend, the boyfriend, the wife, whatever, you know. So yeah, I agree with whoever asked the question. Family should definitely be involved. It's something that we, because we know as firefighters, we're very apprehensive about going to the doctor just because we deal with sick people all the time. And I think it's just like our natural defense mechanism. I think that having that support and having that encouragement from your family to say, hey, I need you to stay healthy if you want to do this, right? So I always tell my people, you know, we signed up to do a job to care for people, but you can't take care of people if you don't take care of yourself, right? So that should be like your motivation to say, okay, let me at least try to get these screenings in, or just see a primary care physician and be evaluated, whatever, proactive about your health. So
Awesome. Great feedback. Yeah. Oh, sorry, Dr. Green.
Our goal is, like I tell them, my goal is not as a clinician for them to not get cancer or not get heart disease. My goal is for them to live their best life, so to speak, right? Like optimal health prevention is where the key is. And, you know, if whether that means catching something early or that means preventing it altogether, but just optimizing everything that we can from every perspective on the job, lifestyle, you know, their home life, their family life, everything possible. That's like our goal for them. So it's a little bit beyond just, you know, we go a little bit beyond just like the regular doctor type of thing. Like we genuinely care about everybody that walks through this door. So I think that makes us a little bit different.
Well, no, Dr. Green, we've reached the end of the road today for our seminar series. I know you guys are busy with the mobile van out to really see patients today, so we will let you go. But to our attendees today, the conversation doesn't stop here. We invite you to join us at our website and ask more questions. If you go to sylvester.org/firefighters, you can learn more about the mobile van and some of the activities and research projects that we're doing. Next month, we have another exciting Firefighter Cancer Initiative seminar presented by our very own Dr. Sylvia Donner, the chair of the biochemistry department and director of our environmental sampling program. And so you'll hear more about from her for next month. I'll turn it over back to our lead administrators, Ms. Theory and Ms. Greenberg. Anything else I forgot? Absent-minded professor to mention here?
Just one more thing. If you are interested in continuing education credits, please send your FC DICE number to the firefighter study email. It's just firefighterstudy@miami.edu.
And as always, recordings of the FCI seminar series can be found on the Sylvester Comprehensive Cancer Center YouTube page on our FCI playlist.
Thank you all very much. Have a great day. Bye.
Bye, everyone.